session for the Protection and Advocacy for Individuals with Mental Illness Advisory Council. My name is Tim Saubers, and I am the chair of that advisory council. I use he, him, his pronouns. And for a visual description, I'm a Latino man with light skin. I have 2 full tattoo sleeves. I'm wearing black glasses and a lavender t-shirt with white daisies on it. And I have yellow hair. And I'm sitting in front of a blue couch with some pillows on it and a white wall. I believe there are captions available as well if that's something that you need. So feel free to hit the closed caption button on the bottom to turn those on. What we're going to do today is that we're going to start by having a little bit of an introduction from Leah, and then we'll hand it over to Ellie Jarvie to talk to us about grievances and how to file them effectively. And then we'll spend the last about 45 minutes to an hour hearing from you guys about your experiences and what you'd like to see Disability Rights Wisconsin and the advisory council really focusing in on and how we can best support you guys in the community across the state. I'm really excited to be here today, and I'm really excited to hear from you guys and to get to discuss with you guys what your concerns are and how we can continue to support you. But first, I'm going to hand it over to Leah.
Hi, everyone. I'm Leah Kitts. I'm the Executive Director of Disability Rights Wisconsin. So nice to see you all here today, and wanted to welcome you and add to what Tim said as far as it's very important for us to hear from people who are experiencing issues or who have opinions about mental health in Wisconsin and what DRW's role in that might and should be. And so we are very grateful for your input, and I'm looking forward to hearing what you have to say, and hopefully we'll all learn a little bit too while we're at it. Thanks.
Thanks, Leah. So to kick us off, I'm going to hand it over to Ellie Jarvie to talk to us about grievances.
Hi, thanks all for being here tonight. I'm really glad to be with you. So my name is Ellie Jarvie, and I'm the lead advocacy specialist here at Disability Rights Wisconsin, and my pronouns are she, her, hers. And for a visual description, I'm sitting near my sunny office window in a plaid green shirt with glasses on, and I've got a Pride windsock to my right. So I'm really glad to be with you tonight. So I'm going to start by sharing our screen. And we're going to be talking about our new do-it-yourself client rights and grievance process. And hopefully you can all see that on the screen. Is that correct? Okay,
yes,
great.
Looking good.
So you'll see that this was authored by a couple of attorneys here, Melanie and Mitch, and Karen Lane, who's a longtime advocate at Disability Rights Wisconsin. She's now retired. And this was probably her last big project for us. So we were glad that she was able to do this before she transitioned on to her life of leisure. So one of the reasons we wanted to do this is because we do get a lot of complaints, calls about people wanting to file a complaint. And so we can always offer technical assistance. Some people are just fine doing this on their own. So we wanted to give a guide so that people who feel comfortable just like grabbing something and going can do that. So we want to let you all know about what's going on with this as well, just so that you can be aware for yourselves and other people that you might encounter. So just to note that anyone can go ahead and use this as long as you don't change it and you acknowledge that DRW is the author of it. So there'll be a number of things. I'll just go through the document. So this first page is just the table of contents. You'll see that it's divided up into sections where we're talking about you think your rights were violated, what are your rights, how to write a grievance, and then finally some samples that you can take a look at. So the first thing we want people to know is that you can find client rights or patient rights under 2 main places, and that's Wisconsin Statute 5161 and DHS 94. And this is specifically for people with any who are receiving services for mental illness, intellectual disability, or an alcohol or substance abuse. And then you'll see a link to the actual client rights website, a web page, which DHS has. These rights here that will that are bulleted are taken right from 5161 and DHS 94. And we're listing here the most common rights that people usually have questions about. Those are things like must be treated with dignity and respect, to be free from verbal, physical, emotional, and sexual abuse. Staff may make reasonable and fair decisions about your treatment and care, cannot be treated unfairly because of your race, national origin, sex, age, religion, disability, sexual orientation, source of funding, or marital status. May not be filmed, taped, or photographed unless you agree to it. You have a right to telephone calls and to make and receive telephone calls within reasonable limits. That's an issue that we often see coming up in the group homes or CBRFs or adult family homes. You have a right to reasonable privacy when toileting or bathing, to see visitors every day, how to spend your money, how you choose, except when someone else holds that right, including the parent of a minor, a court-appointed guardian of your estate, or representative payee. Specific rights about the treatments that often come up: prompt and adequate treatment, least restrictive manner and setting, free from restraint or seclusion used as a means of force, control, or punishment, and people must be allowed to participate in the planning for the treatment or care. And a note that, I talked about the people who could be served under this. It's important to note that if somebody mainly has a physical disability, generally this process doesn't apply, and that you want to ask about your rights as a medical patient and how to file a complaint. People must be informed about their treatment, care, and medications. This includes alternatives and possible side effects. You might have heard that called informed consent before. You must consent in writing to treatment and medication unless it is needed in emergency to prevent serious physical harm, court-ordered, or your guardian consents for you. And you must not be given unnecessary or excessive medication. This next part is specific rights about your records. They must be kept confidential. People may ask to see your records. Your provider must show records about your physical health or medications. And let's put a bookmark in that, because we'll come back to later in the document. There's some specific situations where staff can restrict access to records for a short period of time. So we'll get back to that in a minute. Well, actually, it's right there. When you're receiving services, staff may limit which other treatment records you see, but they must tell you why. After discharge, you may see your entire treatment record. So there you go. It'll often come up that people will be confused about that one, and they can, in certain settings, say that it would be therapeutically inappropriate for you to see records. If you believe something is wrong in records, you may challenge it. And if staff will not change the record that you challenge, they must allow you to put in a written statement explaining why you disagree. So rights about grievances: before starting treatment or services, your provider must tell you about your patient rights and give you a copy of their grievance procedure. Often what will happen is people will get these in part of an intake process where they're signing a lot of papers. So they may misplace it, or they may say, I don't need a copy, but those should be given to you at some point. People should be able to ask for them later and be given one as well. All staff should know about your patient rights and know how to help if you want to file a grievance. No staff should threaten or punish you for asking about your rights or filing a grievance. You may choose to sue in court during, after, or instead of filing a grievance. So one thing that is important to know when we're talking about the procedure is the first person that you'll talk to is the client rights specialist, and that is an employee of the agency you're filing a grievance against. That's often hard for folks because they don't feel like that will be an unbiased process, and they won't be fair. They won't be fair. Client rights specialists do need to go through training provided by DHS, and they are supposed to be fair, and will need to write a written report. And as you'll see, there's many steps where you can grieve that original decision by the client rights specialist. And if you go along far enough, it'll move outside the agency. So something important to know there. We always tell people file grievance as soon as you can. It must be filed usually within 45 days. If you miss that deadline, you can explain the delay and say, this is why it's good cause for a later deadline. Most any place will honor that. If the original agency doesn't honor that, you can grieve that it wasn't honored. So there's a process there too. So you've got 45 days for that original grievance, or unless you explain why, for good cause. And then within 30 days, you should receive a written report back. That'll include a summary of your concern, the CRS or client rights specialist determination about whether a violation occurred, and also it'll include next steps. If you agree, then that's all, just one step. If you don't agree, you may decide to appeal to the next level. It could involve 3, 4, even 5 levels of appeal. So we'll just go through those briefly. First is the informal process, totally optional. You can just have an informal conversation. You don't have to do this. If you do, it's just helpful to note. At the end of this document, we have a log. You don't have to use that log, but we always tell people, just keep some notes. Paper trail is really important here. So you want to make sure to note any conversations that you've had, any telephone calls, any face-to-face. So the first step is that formal grievance investigation. File it with that client rights specialist as soon as possible when the details are easiest to remember. Then we talked about the timeline already, and it should be written. If you choose to file a verbal grievance, the client rights specialist should assist you to write or type it, and then make sure to ask them for a copy. Although the statutes do allow for you to just give that verbal complaint, we always tell people having something in writing is just better. You want to have that backup, and you want to have that record if you have to refer back to it. So step 2, that's the grievance investigation. So now we're into the formal system. So the client rights specialist will investigate your grievance and attempt to resolve it. They'll write that report within 30 days from the date you filed the grievance. You'll get a copy of the report, and it will also be going to the program manager, maybe a supervisor, or even sometimes the CEO, owner of the program, especially in residential settings like adult family homes or CBRFs. Those will often be the folks who get this. It doesn't have to be someone other than the CRS, so somebody above them in their organizational structure, and someone who has the authority to make a decision on your grievance. If you both agree, the recommendation is to be put into effect within a time frame that you agree to. So if your grievance isn't resolved by the client rights specialist report, the program manager must prepare a written decision. This must be done within 10 days of receipt of the client rights specialist report. You should be given a copy of the decision. So hopefully you see all the way along, you'll be getting this paper trail, so make sure to keep those documents, file them if you still use paper, or go ahead and save them in an electronic file so you can look back and follow up if you'd like. If you don't agree with the program manager's decisions, you can appeal, and your appeal should say why you don't agree. Okay, here's where we start to really make some decisions. And basically, the next step comes down to who's paying for the service. If you're receiving services directly from a clinic or program and the county is not paying for your services, you can skip this level and go right to the state grievance level examiner. For example, if you're in family care or IRIS, because the state pays for that, you go right to step 5. Many mental health services, though, are paid for by the county. So appeals about those services would go for the county. Okay. And usually they have the program manager's decision usually goes to the county agency director, and you must make this appeal within 14 days of the day you receive the program manager's decision. So that one's important to pay attention to because that timeline has shrunk now, right? Originally we had 45 days, and now it's going down to just 2 weeks. So you want to pay attention to that, and you want to respond if you're going to grieve it. And you should say why that you disagree with the program manager decision. And you can also describe your suggested resolution if you have one or you want to. The county agency director must issue their written decision within 30 days after you request the appeal. That next step, step 5, is the state grievance examiner. That website I referred to before talks a little bit more about the state staff and their process. If your grievance went through the county level and you don't agree, you'll get there. Or if you're in IRIS or family care, then it'll go right here. And they must, within 14 days of receiving the decision from the previous level, you must appeal that within 14 days. So again, that 2 weeks, once that original one comes, you've got another 2 weeks if you disagree. And then there's the address to send it to. And you should say why you think the earlier decision was wrong. So the final state review, that would be the next level there, step 6. If you don't agree, you can make a request of final state review by the administrator of the Division of Care and Treatment Services. Again, you've got that 14-day timeline. So that's kind of consistent throughout. And there's the addresses down there. So that's kind of the general process. Just wanted to make sure you had an understanding of that. This next piece is, I think, pretty helpful because it talks about what the components of a well-written grievance are. That includes breaking down the problem, explaining why you believe what happened, state what you should want in order to resolve your dispute with the provider. And do you have any friends or allies who may have witnessed what happened? You want to note that, and they give an example there. My friend Linda was with me when the staff yelled at me. State you are writing a formal grievance and that you want a response in writing. Make sure you keep a copy of the letter yourself and document when you mailed it. Mark on your calendar when you called or sent your grievance. The client rights specialist has 30 days to investigate and respond to you in writing. That's where, a lot of our online tools can be really helpful. I don't know about you, but I put so many things as reminders on my Outlook calendar just to ping me to pay attention. So you could do that even a few days before in these processes if you wanted to. And again, you want to keep those copies. This section talks about bumps in the road, what to do or some common questions that come up. Like I mentioned before, this is a really common question that we get is, why should we even do this? They work for the agent. The person that I'm complaining to works for the agency I'm complaining about. How could it possibly help? Again, client rights specialists go through training and they're supposed to be fair. And if you don't agree, you do have steps to grieve up the chain. Client rights specialist just wants to talk it out. I've tried, it never has enough and it never goes anywhere. And just be assertive and say you want to file a formal grievance. How do I decide what is important to include in my grievance? And you really want to make sure you're linking it to one of the patient rights that's listed earlier in the document. If you can really think about which right it was violated, it'll be easier for you to organize your grievance or your story that supports your view of the violation. You don't really have to quote the administrative law or state statutes. It can be helpful to really explicitly say, though, this violates my patient rights. And there's a sample template at the end of the document. And here the question is, boy, I'm not sure really if it should go to the county or the state grievance examiner. How do I know which place? And again, it's depending on who is funding that service. If you're not sure, go ahead and submit it, and they should be able to get it to the right people, and that's the next question. If refiling it in the right places caused your appeal to be a little late, you should request the examiner or county agency director find that you had good cause to file late. And I have seen that happen, and I can tell you that both counties and the state have allowed that to happen. Okay, so what here it talks about, what if something hasn't happened, if you haven't gotten that response in over 2 months, then that is basically another violation. You could go right to the state grievance examiner about this. And this question has to do with Never contacted by a client rights specialist. And then it got out of the blue. Thank you for contacting us. We've decided your grievance is unfounded from somebody I never heard of from the provider's office, home office in Chicago. What's up with that? Then just go ahead to the next level of appeal. Sometimes this will happen if an agency has branches in multiple states. You know, different states have different processes. So that should work itself out as you keep appealing. And then this question is about treatment records. And we talked a little bit about that already, so I don't feel like I need to go over that again. This is a good question that comes up often is I have questions and I think I want to talk with someone about my rights, but I don't think my guardian will let me. And we just really want to stress that even if you have a guardian, people always have the rights to communicate privately with the court or government, have access to and communicate privately with and retain legal counsel, have access to and communicate directly with Protection and Advocacy Agency, that's Disability Rights Wisconsin, and the Ombudsman or Board on Aging and Long-Term Care. And there have been times when I and other advocates need to assert that rights, and we see that mostly in the adult family homes and group homes. We'll have staff that will restrict our access. They'll say, well, somebody has a client rights restriction, or, you know, they have a calling plan. And usually that's resolved by me just explaining where that is in the statute that we're one of the two agencies that is exempt from that. And we'll get that call set up so people can talk to us about their concerns. And you can see why it would be important. You don't want any closed system where people don't have an ability to be able to grieve or complain about their treatment. So the client rights specialist told me they won't accept a complaint unless it is in writing or on a certain form. I've heard that one a lot, and that is false. It doesn't have to be on any specific form. Again, we always encourage you to write it, but if you're not comfortable for some reason, you can rely on that client rights specialist to do it, or even better might be to get a friend or another advocate to write that out for you. Having that in writing is really one of your best protections. And again, just that if it's outside of that 45-day window, if you can identify a good cause, and one good cause is failing to investigate the grievance would cause substantial injustice. And there's an example there about that. I won't go through all of these examples. And again, here we talk about some examples, some simple ways to write a grievance, and some common issues, and these are ones that have come up for us: prompt and adequate treatment, violation of rights to confidentiality, the right to privacy and not to have your picture taken, right to use your own money. So basically, some key points we'd like you to remember is remember that you can appeal, and that some grievances are settled quickly, but others take longer, and they do go through all the levels. And really, I can't say enough, keeping copies of those documents and timelines are important. So you'll see, so we've got some appendix here too. We've got a grievance letter template, and grievance letter after using the template, how that would look. A worksheet, this can help people kind of really lay out their thoughts before they write that grievance. Pressed for review or appeal. And just basically a call log, you know, so you can keep track of phone numbers, emails, who you're connecting with. So that's generally the client rights packet. We just wanted you to be aware of that new resource that's out on our website, or updated resource. We as advocates still are available for technical assistance to help people through the process. So I don't want you to think that, you know, this is the only resource for you, but for those who'd like to go ahead and do it on their own, it is something that we offer. Any thoughts or questions about this?
Ellie, do you want to maybe stop sharing your screen? So
Sure.
it'd be a little easier to see the room. Great.
Oh yes, that would be a great idea. I can definitely do that. Let me just get this big enough so that I can hear again. Okay, bear with me. It's have to open this up. Can you do that as co-presenter, Barbara? I'm having a hard time getting this window big enough. Oh, there, I'm able to pull it now. This should be able to do it. Got it. All right. Well, if nobody has any questions for me,
I think there were a few questions, actually.
Oh, okay. I'm sorry.
There's a hand up. I'd be happy to help with that if you'd like, Ara.
That would be
has
wonderful.
the hand up. So go for it, Ara.
Okay, well, I have plenty here. The first one has to do with that timeline. If there are multiple ongoing instances, how is that timeline defined?
Sure. So typically what happens if it's helpful to chunk all the issues into, if they're the same issue, you can take a look at what the violation is, what client right do you believe was violated. And if they all have to do with privacy, for example, you could take a look at the last instance that occurred and maybe refer back to the others. If it's multiple different rates that are violated, it can be helpful to file multiple complaints. That's usually what the client rights office would rather see rather than put them all together.
And as far as a client rights specialist, what if the agency tells you they don't have one? And as far as in the agency, who is allowed to hold that position because of conflict of interest?
Sure. So the agency has to identify somebody, and that person has to go through training provided by DHS. Oftentimes it is somebody like a program manager. And so that's often a question people will have is they'll say, well, it doesn't seem like this is a fair process because the person that I'm complaining about is the person who oversees the program, or maybe the person themselves I'm complaining about that is looking at the grievance. We tell people still go through the process. And that's one question I have for all of you, is that, if you could help us get the word out and let us know and let people know it is still worthwhile going, if you don't get satisfaction at that first step, you can take it to other steps where, all the way up to the state where people outside the agency will take a look at it. So helping people to know that it's there and it's worthwhile, even though it's cumbersome, I think is a way that we could have folks on this call today be helpful.
Okay. What if the agency does not produce any documentation for you?
So if the agency wouldn't produce, you mean like a written response after you've given your response? Well, that would be something that you would take up to the next level. Then I would take that right to either the county, or you could go right to the state grievance examiner in that situation. So if it's been, I think the example they have in the packet is, it's been 2 months and they were supposed to respond within 30 days. And then that would be something you just take up to the next level.
Okay, so my take on that is, even if it's not a formal grievance, you should still produce documentation.
So if you're just doing something informally where you're having that discussion, I would
Where
make
you're
it
starting from there.
Yeah, I guess I would make it clear to the folks you're talking with that you'd like some documentation. And I guess if you're wanting documentation, I'd wonder why you would want to do a formal grievance. It might be easier to just track and pay attention.
Yeah. And this one I've actually seen in multiple agencies.
Yeah.
What if the list of client rights they give you is not complete? Like they don't list something about receiving mail, or they don't list rules about visitors. Like what if?
Sure. Well, you can always go to this document or the document on the client rights website and pull off the full list. Just because they don't list it on there, it still is a client rights.
Yeah, that's kind of what I thought. And what if it is a staff person that is seeing client rights violated and the client doesn't want to file?
So it's always our position at DRW. We're strong believers in self-determination. So if somebody doesn't want to file, I wouldn't ever compel them to as an advocacy specialist. What role are you working with that person in?
I am actually a resident aide in transitional living.
Mhm,
And there is somebody in our agency that I see that just blatantly ignores things.
mhm, mhm,
And often, it's a different client, but I see the pattern.
mhm. Yeah, so I don't know that that would be so much a client rights specialist or client rights grievance issue. Although I can see why you would see would be concerning. I don't know if you've tried talking with that person directly or going to their supervisor, but those might be places to start
Okay.
in your situation. Really good
Um,
questions. Thank you.
Yeah. My other one is kind of technical. When it comes to using a picture, say they signed, that you can take their picture. Does there need to be language about a timeline and what the picture can be used for? For example, you can use it for this, but not put it on the internet.
Well, I'm not going to get into the details of photo release because I am an advocate and am not trained as a lawyer.
Okay.
But I know just I don't know if anybody else wants to jump in and answer that one.
I would just say ethically, even if it's not legally, they should be making sure the photo is used as the person wants.
You have to look at what it says. It's, somewhere probably buried in small print near the bottom, it'll say, this photograph now becomes the property of Happy Valley facility, and then they own it. And if you don't want that, you have to cross it out and initial it, and say for annual report or for the brochure only or whatever. But you have the right to do that. You just have to be very careful because they can't tell you it's just for the annual report and then use it anywhere without getting another release.
Okay. I think that covers everything I wrote down.
You came prepared. I like it.
Ellie, there was also a question asking about emailing the guide. And I put the link to the guide in the chat, and I'm
Thank you.
happy to try and send a follow-up email to the list who's registered for it and include the link to the guide. The link was also on the flyer. Sometimes that might not be real clear, but that is a live link, so you can just click on it and see it. And if anyone needs the material in an alternate format, let me know. It should be an accessible PDF if you use a screen reader. But if there are any accessibility issues, please let us know. We want to make sure that you have access.
Very true. Very true. All right. Well, I think I'm right at my 30-minute window that I know Tim wanted us to keep to. So if you ever have any other questions, don't hesitate to give me a call here at DRW, or you can send an email. I'm more than happy to talk with folks. And I always like connecting with the PAIMI Advisory Committee and the good work you guys do.
Thanks, Ellie, and thanks for sharing everything that you did. I think that document is so important, and it's so helpful to have it all in one place like that. I think, anybody who's navigating systems or working to support other people navigating systems, it could be extremely beneficial to you guys to keep a copy of that on hand and to share with people around you. But what we're going to do now is switch to kind of hearing from you guys. So I wanted to just take a minute to kind of share the purpose of the advisory council for those of you who might not be familiar, so that you understand a little bit more about like the context of what we're doing and why we want to hear from you guys. But our goal is to advise Disability Rights Wisconsin regarding advisory priorities each year. So that could be like looking more specifically at what different institutions are doing, keeping an eye on how different systems work, looking at grievances. But one of the things that's really important is that we hear from the community so that our decisions are guided by what people navigating those systems or people working to support others navigating those systems feel like are really important advocacy needs, excuse me, and spaces where there's room for growth. So what I would like to do for the rest of the time is really just hear from you guys, like, where do you feel like there's space for advocacy within systems? Where do you see harm being caused? We are covering the whole state and we are working at more of a systems level. And so I'd really encourage you guys to focus on more large scale, like this is something that we're seeing consistently, or this is something that we've heard about for a long time, rather than maybe more specifically, like this is what like I need DRW's help with this thing right now, because that's unfortunately not something we're gonna be able to do in this space. So really interested to hear from you guys, like, where would you like to see advocacy within systems that provide mental health care? So it could be schools, it could be institutions, it could be behavioral health care centers, it could be vocational spaces. What would you guys like to see?
Hi, everyone. This is Margarita. So I have a son living with disabilities, behavior, and mental health. And I really think, especially now, that there should be more offered to children, to students, to teenagers, with everything going on with the high schools and in the area, that there or something in regards to mental health and offering to help more with that. And it's not just people that have disabilities also, it's just mental health in general. There's so many things going on, and I've tried to talk to people in the high school to ask them, and they just say, well, that's not, we don't have funding for that, or there's a counselor. But it seems like there's a need more than just a counselor.
Yeah, so seeing like expanded access to services in schools and for teenagers or youth navigating those systems.
Yeah.
Hello, my name is Tiffany
Sure.
Stark. I would like to thank you guys for having this. I will say something across the board. I'm a mental health provider. Something across the board that is affecting all of the systems with youth, adults, everything. There is a shortage of workers. For example, right now, it's hard to hire people. Right now, I am in the Milwaukee area, and in the Milwaukee area, we've been trying to open up this new mental health clinic forever, probably since I've been born. And it was supposed to open, and now it's been postponed to September. And the number one reason is a lot of the staff that was going to go there backed out, and they don't have clinicians. Another big issue in Milwaukee is police and mental health and training. And the Milwaukee County Board had approved the CART team and funded it. They can't get people to work. So here we have this vital, option or service to help police and help the people in the community, but we can't even put it in place because there is no clinicians to fill these jobs. Same things in the school. The big issue right now is even people getting out of school, they are struggling right now, and this is a big systematic issue. Department of Professional and Licensing has 4 people that work in the office. There's people sitting there that need to get their tests, need to get their license. I know people that had to drive to Madison to go to this place to get face-to-face or some contact because people are sitting waiting to hear back regarding their licensings and their exams, and once they pass the test, they're sitting there and they need that documentation to get into the job. And so there's 4 people working in that office across the entire state of Wisconsin, and that is holding up important key, positions for people to fill these positions. So we have a real issue right there. That's a lot of the systematic issues. I could be here all day from my own experience with individuals. Milwaukee County has a major issue with services in general, providing services. It takes 6 months to see a psychiatrist. I was a CSP case manager. I had clients on wait lists for months for services that need service besides taking medication. Medication is great, but there is no pill for trauma. I have people that have trauma and need therapy sitting on wait lists for 6 months. I had a client stab herself. Oh yeah, well, now she can get therapy. Well, why couldn't she have gotten it before it got to that extreme? There's a lot of things that aren't being told. And I will be honest, and I'm a person that I will speak the truth. I know Dontre Hamilton and the entire family. I've been with them since day one. I was at Dontre Day. Milwaukee County got up and, made it sound like all these services, that they do have, but they're not really being offered. And we need to start and be in the beginning of being honest so we can move forward. The services you may have, but they're not accessible. There's wait lists. There's not availability. People are in bad shape right now prior to the pandemic. Now the pandemic, it's worse than it's ever been. It is awful. And we need to be honest and say what it is so we can move forward and figure this out. An idea also with the mental health board that was kind of brought up, there's this opioid settlement money, and trying to figure out how they're going to spend that money, and possibly spending some of that money on being able to market jobs or being able to fill the gaps to provide more services to alleviate these wait lists. I mean, like I said, I think I'll stop here because I could be here all day. It breaks my heart being a provider and to see what I had to see people go through that don't have the services that they deserve to have.
Yeah, thanks, Tiffany. What I hear within that as well is really like a lack of equity in terms of not just access to services, but formal training and education in order to provide services to begin with. The level of schooling that's required, the level of training that's required, the amount of time it takes, the amount of money it costs to become, excuse me, a clinician is extremely high, and it doesn't get recuperated in the amount that you make when you're working, right? It's extremely arduous process for very little financial payoff in the end. And so we've heard pieces around that being an issue. But also what I hear within that too is like, it takes such a long time to do that. And the issue with the public licensing, I've definitely heard before that is really holding things up in terms of getting people able to work. But also within a lot of these pieces, like either in the meantime or instead of, does it have to be a clinician? Are there other like behavioral health technicians? Are there peer specialists that could fill some of these roles that require less training, that can fill these positions quicker? And they are typically, unfortunately, paid less, which is a huge issue here as well. But really looking at like, how are these systems and educational pieces designed and how it impacts our ability to receive and provide services to people who really need them.
I would like to speak up on a couple issues. I'm a little touched today because of an incident in our neighborhood that ended badly with a person in psychosis who was apparently taken by police to two hospitals, apparently, who discharged him still in a state of psychosis, and he is now deceased. My issue with this incident, and much earlier than this, is just why is the private hospital system allowed to discharge at their own volition when places like the county do have to discharge to somewhere? The private hospitals can apparently discharge to nowhere. And a person who's in a state of psychosis is left to wander and find their way through that mess. And I just wish and I hope that the private hospitals in our community would have a standard to release a person who's ill to some place, to a family member, to a friend, to a place they can go to be safe. And that is my observation over many years since things have gotten more private. There just seems to be no standard no common standard for these institutions. I know county had to rescind, I guess, in the past, their option to release to the streets. They had to rescind that. They have to release someone to a location. It is extremely dangerous. It's probably everybody who's working in this field knows, to release someone who is not, who is delusional or have experiencing delusions or psychosis to their own volition. It was just a very big tragedy. I wanted to voice that today. I want hopefully this to change for our community, because it's not the first time. And the other two issues I had to bring up, I just wanted to bring up, were pregnancies. These are from personal experience. I've been advocating, I've been hoping someday that doulas in mental health could be provided for women experiencing mental health issues from onset of pregnancy through the first couple years of the young child being born. Would save lives, would save families. This is not, it's always a cost matter, but it's really, really unfortunate that women don't get this kind of attention when they have a vulnerable pregnancy going on. Other health issues, they do provide doulas, but with mental health, as far as I know, they don't. And then the only other issue I wanted to bring up is, this is also out of personal experience and work as a peer specialist. So often housing in the community is either in an apartment specified for mentally disabled, or if a mental person experiencing mental illness ventures out in the community on their own to live independently, they're often preyed upon by other persons who see that person receiving possibly disability or some way to pay the rent. And pretty soon their apartment is overrun with people. And I just wish there were, I would like to advocate for a kind of a mediation with housing. If you want to provide people who can mediate these housing situations, rather than call the police. A lot of people with mental health conditions, and I'm a consumer, hesitate to call police and get that involvement done. But to have a group of people come out to the apartment and speak with the people there about, what is legal and not, whether the people, whether this is a fair situation or not, and kind of resolve it before police would be called or someone would be hurt. And those were the three issues I wanted to bring up. And I'm sorry to be loud if I am, but I was very, very saddened by this recent death. And across the board, I'm completely baffled why a hospital could release who's supposed to care for those with this condition, release a person in that condition to the street. And it's happened in our family as well. So I just wanted to voice those three concerns. Thank you.
Thanks, Janice. Yeah, so you listed several things: a greater oversight of privately funded hospitals and healthcare providers, specifically around mental health and people who are hearing voices or seeing visions or experiencing altered states, connecting mental health to people who can get pregnant, including doulas for extended periods of time, and then long-term support after this person has given birth. Excuse me, and then some pieces around housing as well. And underpinning all what we've heard so far, I also hear advocating to move away from police response and engaging with law enforcement, with people who are navigating mental or emotional distress. That there needs to also be a big component of a lot of what you guys have shared is law enforcement involvement or engagement with services where law enforcement doesn't need to be involved. And so I hear that as well, that and I'm going to speak for myself here. Sorry, you guys, the allergies really are killing me today. But for me, what I hear within a lot of this too is that this idea of co-response is not working. that sending a peer specialist with law enforcement doesn't make that situation better. There should just be no law enforcement. And it could be a clinician and a peer specialist together responding to a mental health emergency. And so for me, when I think about advocating for systemic change or response within institutions, it would be moving even further away from these co-response models and just boxing the law enforcement out completely. And really looking at how do we move past that. When we provide these co-response opportunities, people think the problem's been solved when it really hasn't. And so for me, that's a piece that I really like to see advocated around as well. Hope, go for it.
Shaky hands and trying to unmute. Anyway, you brought up a really good point, Tim, that was going to be what I wanted to talk about, is related to having suicide being a police illegal, and then police involvement. I've had personal experience with that, and you know, that is more traumatizing. You know, you're at your lowest moment ever, and then police are involved, handcuffs are involved, riding in a police car is involved. So I don't know what the true answer is, but I would like to see that worked on.
Yeah, definitely agree, Hope. And I hear within that too, like linking a little bit back to what Tiffany was talking about, some of these CART teams or these crisis response teams that are like a clinician and some like a case manager going out to check on this person instead, and being able to connect crisis to those folks rather than law enforcement. I don't know off the top of my head, and anyone's welcome to chime in here, if suicide is illegal in Wisconsin, if that's, it still is. I don't know. But if it is, that's definitely a space for some advocacy, decriminalizing like an attempt on your own life for sure.
Can I join?
Please.
So I have one more day of alternatives to suicide training through Wildflower Alliance. And okay, you know of it. And miraculous and eye-opening to me how much it works versus having mental health criminalized and having that stigma. And I just offering it up, I think their method is a solution for probably a good number of people, not all though.
Definitely, Ara. So like really exploring what already exists, what solutions are already out there, who's already doing work in some of these areas that could be connected with, or that we could advocate that different people are trained in, or moving models in different directions. For those of you who aren't familiar, Alternatives to Suicide is a really exceptional training from Wildflower Alliance. Wildflower Alliance is based in Massachusetts. They do peer work, including peer on respites, as well as Hearing Voices Network, some intentional peer support training, as well as Alternatives to Suicide. And those are specifically support groups, Alternatives to Suicide, where people can go and share what they're feeling and experience with no threat of having anyone called on them, whether that's law enforcement or clinicians, and where we trust that the people experiencing distress know what they need better than anybody else. And so it really creates the space for people who are having thoughts of suicide to share that openly and receive support in a space that is non-judgmental and safe. And it really shifts how we understand emotional distress away from something that needs to be corrected to something that's natural and is experienced by all of us that can be navigated through with the right support. So it's a really great model. I would really encourage you guys to check it out if you get the chance. So I'm interested in revisiting kind of the school settings. That's something that we've heard consistently, people with mental health challenges within schools not having access to services like Margarita was sharing, but also just not, experiencing still like seclusion and restraint, not having access to, what are they called? IEPs, individual education plans. I'm interested to hear your guys' experiences and what you'd like to see in school settings as it relates to mental health services.
Well, I know at a time when police or people are jumping up and down saying we need more police in schools. Kind of on the opposite end of that, it seems like more police in schools leads to more arrest of children who are having mental health challenges. Kids that are being handcuffed because of what's in the news, they're repeating certain things that they're hearing. These are being taken as threats, and Department of Justice now has a form that if the child mentions any sort of weapon or a threat, that this has to be filled out. An interview with a parent, an interview with a student, an interview with the staff, interview with an administrator. It's quite a process that I just sat through with a parent, going through a school threat analysis, something like that, through the Department of Justice. As far as mental health in schools, I think at this point, after COVID, and now with school violence, we're trying to put out an inferno with a garden hose. I used to think we needed more providers in the school. I think we need to kind of turn that upside down, and we need to add mental health from possibly licensed providers to come up with some sort of curriculum. And let's just assume at this point that all our children have some sort of mental health challenge, and treat all our kids as if they do have trauma or they do have a mental health challenge. I don't know if it would hurt if they didn't, but I think something needs to be added for all students. I think putting providers in schools and plucking one student at a time is just right now not effective. So that's my opinion.
Yeah, definitely, Teresa. Rerouting some of that funding that goes to like school security officers or law enforcement into some other places. And as we've seen historically, and as the data shows, those school officers aren't actually beneficial. Like you mentioned, all they do is increase arrests, typically of Black, Brown, and Indigenous people in schools. So it'd be interesting to explore like what you were talking about with the, excuse me, with the curriculum development and seeing schools move more into like a trauma-informed understanding, just that everybody's experienced stress of some kind. At this point, I've been out of school for a little bit, but I can only guess that it's probably just stressful for the kids to go to school at all, constantly seeing the news and everything that's going on. And so how do then the schools, kind of do their due diligence of supporting the kids that are there through mental and emotional distress?
I can't find the hand raiser button. I have no idea where it is. I'm sorry.
No problem.
So I really need to voice a bit of an opinion. My son is now 20, he'll be 28. But when he was at 8th grade, he was told, 7th and 8th grade, we were told by a school counselor that when he was being bullied, he had to learn how to deal with it. And we had thought in probably the last 10 years, 12 years, that maybe that bullying had changed a little bit, but I'm seeing still friends who have little kids in school are still being told that no, they have to deal with it. And we're seeing younger and younger kids commit suicide because they are having to try to deal with bullies at school and they're getting no support. There's basically not a lot of backup for them. So I think that's also one thing between peer pressure, bullying, cyberbullying, that still needs somehow to take a front and center on what's been going on, as well as, these school counselors. And this was a special ed counselor that had talked to us and told us that. And I'm not going to lie, I was pretty shocked at the time. But my son was also one that, after repeatedly trying to ram his head through a brick wall, was handcuffed and taken to juvenile instead of taken to be to the mental health institution for an emergency detention. After a doctor had said, please detain him, and the police said, no, we don't want to do the paperwork. We don't want the overtime. So they took him to juvie. So, things just have to change. And I can honestly say, in the last 12 years, I've not seen any of these changes in this school system, especially around the Madison area.
Yeah, thanks, Camilla. So underlying, again, a lot of this, I feel like I'm hearing like budget issues as well. That different pieces of these systems aren't funded well enough, which I'm sure that we're all aware of. That not enough money is going to where it should be going. And I believe, and would definitely appreciate if anyone else wants to jump in, that DRW was engaged in some advocacy around the biennial budget that was just happening, right? So they know that there was definitely some pieces that were being worked on from DRW as well there.
Yeah, thank you, Tim. So you asked about the biennial budget. So the point that we're at right now is the departments are putting together their budget proposals that they'll be submitting to the governor. So it's relatively early. So we have put together a number of proposals in the mental health area, and we have shared those with the DHS Secretary's office and with other areas, DPI as well. So this is a good time if people have ideas to be, share them with us. I think the session has been really informative. And the other thing that I would point out to people is that there's going to be record turnover in the legislature this year. 25% of state legislators are going to be leaving. They're retiring or taking other jobs or moving to other elected office. So what that means is that all of us as advocates have some heavy lifting to do to educate them about the need for investing in mental health services and special education services and long-term supports for children and adults. So we really need all hands on deck. So we are going to be putting together through our work with the Disability Vote Coalition questions for people in the grassroots to share with candidates. And we can push those out to you, encourage you to consider doing that. And that can be a way to start a conversation with the candidate and try and influence their priorities. So it takes time and effort and contacts, but constituents can make a difference. So hope that all of you will share the good ideas and suggestions you put forward tonight with policymakers who may have the opportunity in the next legislative session to make a difference.
Yeah, definitely. And I know some of the pieces that we talked about included like expanded funding for peer run respites, looking at a lot of different peer services, but definitely interested to, excuse me, to hear from you guys. Like, I think one of the things that we struggle with often is like, what do we not like? And so what I'm really interested to hear from you guys is like, in an ideal system, what would you see? What would it look like? If we had all the money in the world, what would that go to funding? And what would you like to see?
I wanted to talk more about school for like adults.
Please.
Because I know I tried to go back to school, like try a technical college in before COVID. It was like 2016. I was living in Racine, and they have the technical college there in Racine. I can't remember what it's called now, but I tried to go back, and navigating going to school, when you have a mental illness and you have learning disabilities, because I have agoraphobia, so it was really challenging to even go to school and be comfortable with going to the school, instead of like virtually going online and everything. But I was basically told that if I wanted the tutors and stuff to help me, that I had to go in because they didn't have enough tutors online. And I don't know if that's changed since then or not, but I was like, well, it would be nice to have like online tutors as well. Because it just seemed like I was going in a lot in person to get the tutoring and everything that I needed for my classes. And that was very hard. So I had to drop out because I just couldn't handle going in as much as I was. My anxiety level just got really high for me. But I also felt like I wasn't really getting help navigating like how to get through like what classes to take, because I was taking classes for professional communications because I wanted to become a writer, and they tested me and they said that that I didn't need the pre-courses, so they put me into the regular course. And when I got into the regular course, I was like, well, this is really hard for me. I thought that they should have put me in the pre-courses. So I don't know how I tested, you know, to skip the pre-courses, but I was like, well, that was kind of ridiculous because that's another reason why I was struggling, because they didn't put me in the pre-courses. They just put me through because they said I tested to where I didn't need the pre-courses. And I'm like, well, I don't know why I would have done that, you know, how I did that, because it was so hard to go into the regular courses.
Yeah, so Angela, really what I'm hearing within all that is a need to expand, and I guess not necessarily expand, but not forget that when we say schools, we also want to make sure we're talking about colleges, university systems, technical colleges, trade schools.
Mhm.
We're not just talking about youth navigating school and educational systems and settings, and making sure that those systems for higher education or education for adults are also taking into consideration people living with disabilities or navigating mental health challenges, in order to make sure that people can access those services equitably and in a way that matches everybody else's access levels.
Mhm.
And then I see in the chat, we need to overall decriminalize mental health. Tell me more.
Oh, boy. In general, people are getting locked up for things that are mental health related. Not only that, when you get into, this goes along with what Tiffany said. I have a coworker whose son, who has a drug addiction, had a psychotic break, and he stole a car in front of the police, crashed, and was arrested. This gentleman has no idea what he did. He's floored that that was him that did this. Everything is straight up legal. There's been no services offered to him. Mind you, he did this coming out of a hospital where he should have been held when he was in this state. And
Can I add
Go
to
ahead.
that? So I had a client of mine that I barely seen him the whole entire time I worked at this agency because he was incarcerated. And when he was incarcerated, he was not getting medication. Of course, let's release him. He comes back out and it's like literally maybe a week or 2 weeks and I'm getting the call. He did something. He jumped out a window. He hurt me. He did something. Well, how do you expect him to be able to be successful when you've already set him up to fail because he's not psychiatrically stable to come out, and then you put him in this environment and he's not stable, and then he does something and then he's revocated again, and then he's in there for another 6 months, and then we do this again like 4 more times, and it's just insanity, and it's so unfair to this person. And I also think we need to understand the biochemistry with people going on and off medications. I also had another person that went off their medications, and when they finally were put on a commitment and they got back on the meds, they never returned to their prior baseline functioning they were never the same again. So we have to understand also the chemistry and what this does. And one other thing with this issue in Milwaukee County is, there's commitment hearings and there's people that have been on commitments, and they're on commitments for a reason. They have a long history. And when they're on a commitment and they're taking meds, they're doing great. And that's the whole point of it. But we have a where the commitment judge, we have rotations of court judges. And right now we have a judge that's really into client rights, which is great. But a lot of people have been not getting their commitments extended. And now we have people that aren't medicated and are in really serious, dangerous situations because commitments are not being, extended when it's been a long history where people have severe murder or severe situations in their past, but they've been stable on meds, and now we're not extending their commitments, and now they're in the community, and unfortunately they don't have the best insight, and now something bad happens. I get client rights, I get it, but at the same time we need to understand, we need to look at the safety for that person as well as people in the community. And to be so liberal or so lenient on these commitments when they've been on a commitment, there's a reason why they're on a commitment. And now we're sitting there trying to, run around and try to get something on them that they're dangerous, which is basically you got to wait till they hurt themselves or someone else to get them back where they need to be. And it's awful to watch a person decompensate where you don't know if they're going to be alive if the police show up, but there's nothing you can do to save them because of the way the system's set up. And it's kind of like you were talking about the private hospitals. A lot of times these hospitals, once they get there, sometimes the paperwork is not filled out properly by the police and we cannot keep them. Even though we know they're sick and they need help, we know that they're sick and they're not in their right mind, but we can't keep them because we don't have enough to do an emergency detention or hold because the witnesses or whatever happened was done prior to them getting to the hospital and it wasn't done right and it gets dropped. And then at that moment they get to the hospital and they haven't done anything dangerous enough to themselves or anyone else on the unit of behavior wise, we have to let them go. We don't want to let them go, but we don't legally, the way this court and the system of Wisconsin statutes is set up, we cannot hold them. And it sucks because it's like, they're not well, they're sick, but you're stuck. And it's like, there's this fine line between client rights and understanding safety and their well-being. And it's hard because everybody interprets that differently. And that's where we are. And we really need to get better understanding of what mental health is and mental health wellness, and looking at this as something people can recover from instead of this stigma. Most people that are people with mental health are not perpetrators of crimes, they are victims. And we need to understand that we need to treat this just like if you have cancer or diabetes. You do the things you need to do, you can be well, you can be in recovery. But we have this negative stigma that those people are different and there's something wrong with them. They didn't ask to be mentally ill. They did not. And I cannot believe all the years I've been out of school learning about all the things I learned, and we're still in the exact same spot I was 20 years ago, and we're still not treating the person and the whole person. We're doing things separately. We do AOD over here, we do mental health here. Hello, mental health and AODA go to hand in hand. Why are not we treating these things at the same time? It's like we're stuck with being able to look at the person as a whole person and give them everything they need, except go over there and do that, go there and do that. That is not the way you should be providing services. It should be one stop, all dual diagnosis. I don't know a lot of people that use substances that don't have some kind of depression or something going on in their life, versus people with mental health. Some people cope because of the voices and they use substances. So why the heck aren't we not treating this all at the same time and treating it so people want to come in and feel like I'm going in there to get my A1C drawn to see what my, my diabetes level is, or I'm going in there to get labs done to see what my iron level is. But we have this stigma and people don't want to walk in the door because they feel they're treated differently. And I'm sorry, they are being treated differently. So sorry, I get on my soapbox, but I'm so passionate about it because all people want to do in this world is have a meaningful life. Whatever happy and normal is to them, that's what it is. But it's like we can't even get there because people aren't even being able to get their needs met. They can't even have a place to lay their head. They can't even get their medication, or their provider leaves and then, oh, well, you got to go back on a wait list. Oh, in the meantime, well, I need to take my meds. Oh, well, you're on a wait list. Oh, well, in the meantime, now my life's falling apart, because I don't have my meds. To function, to go to work, to take care of my kids, to do what I need to do as a normal person in the world, but I don't have my meds, and now I'm struggling. So I just get so upset about it because it's like, to me, it's common sense, but we're still in this world, how many years later, still judging people and treating them differently, and people do not ask to deal with this. They're humans.
Definitely, Tiffany. Lots of good stuff that you're sharing. What I hear within that too is a lot of what I draw out from that is that there needs to be advocacy for expanded understandings of what's considered mental distress and wellness. I would love to see advocating for expanded services that are not clinical, that don't center on just taking meds and going to therapy and treatment. I would love to see advocating for expanded training and education around decolonizing mental health services so that we don't think of everything as a disease or something that needs to be cured, right? There are lots of cultures that understand hearing voices and seeing visions to be exciting spiritual experiences or deep, meaningful life events, not things that need to be cured through medication, not things that need to be addressed or corrected. And when we expect those people and those cultures to then receive services from a Eurocentric medical model service system, they don't get the support that they actually need in order to be well as they define it. And so within that, I really hear expanding services that are not clinical and expanding training and education to include, I don't want to say alternatives because that makes it seem like the medical model understanding is correct, but additional understandings of human experiences and mental wellness and what recovery can look like. So we've got about 10 minutes left, and I want to make sure that we have just a few minutes at the end to close out and wrap up. And I know Barbara has some a voting piece of information that we want to share as well. So really, excuse me, would like to invite you guys in the next few minutes to just share any final thoughts or anything else that you guys see as systemic spaces where you'd like to see advocacy or things change, thoughts on the budget, just anything that you'd like to share regarding mental health services in Wisconsin.
Well, I just want to say a couple of words that come to mind is safe spaces, places where people are safe. When they discharge, I think the problem's not with discharge with me, it's with having nowhere to go on a discharge of a private hospital. So a safe place and real advocacy coming from where the person's at. Because I'm a person who experiences psychosis, and I have had experienced psychosis, and really could have used an advocate to help me voice what my needs were at the time. So advocacy where the person is at, whether it's a child, an elder, or a person in another, alternative state of mind of being, those two things I'd like to say, advocacy and safe space.
Definitely, Janice. I think that's something that we've heard consistently is that like there's not enough housing, there's not places where people could go. I've just individually really talked a lot about how there needs to be greater partnerships between the Huron respites and existing hospitals and other systems so that they could be discharged to there. Or they could be, if you're like navigating substance use, you're in a sober living house and you have a return to use, instead of being kicked out, like could you go to the Huron respite for a week and then come back and not lose your bed? And so I'm with you, Janice. I think there are some existing pieces that there's some things that already exist. I feel like some of the pieces are already there. And so how do we advocate to get them to work together more effectively than what we're seeing right now?
Thank you.
I guess I would like to see more funding in schools and with police. I know that they advertise heavily that one of our police agencies in our area has a social worker that can go out on calls. Well, a social worker that can go out on calls sounds like a stopgap to people wondering why those with mental health are being arrested or killed at a higher rate. So I guess I would rather see all officers trained with some sort of social worker, something. Same thing with schools. We have a counselor that comes to our school twice a week. We need more than a counselor that comes to the school twice a week. We need a broader blanket curriculum-based mental health education in schools and with our police. So if money were no object, I would make sure our officers, I would love to see them have social work degrees, or at least some sort of degree in just being kind, for gosh sake. Same thing in schools. I just would like to see a blanket training for those organizations.
Yeah, so expanded training for law enforcement. I think we hear that pretty consistently, that they're, law enforcement agencies like to say, like, we have one CIT trained officer that can respond, if he happens to be working that day and available at that time. And so like training all of them and increasing services at schools as well. Marguerite.
Hi, yes, I know, in speaking of police officers, I know here in Madison, in the Mineral Point area, in their new building, they do have a mental health officer. I know that when my son had a situation that happened in the 7th grade, he's now a sophomore, we did get in touch with the mental health officer, and they invited him, we talked to him, and they have all of Joshua's information. So in case something were to happen, it would be like on his little, when they pull up his name or something, it would say, that he has, and lives with disabilities. But yeah, I do agree with that. I think, and I know that some of you are going to disagree, I think that SROs on the one hand were a good idea to have somebody that knew the students themselves. I know that there's officers that if something were to happen at school would come on the scene and not know the students that are there. You tend to get to know the students in the schools, which ones have challenges, which ones are good kids and make mistakes, and which children are more coming from a criminal side. So not all the children from disability mental health would be criminalized, because the officers that would be there would also already know them. So there's a good and bad to that. It's just really, really challenging. If there was no limit on funding, everybody in my world would hold hands around the campfire singing Kumbaya, and whenever something happened, to be able to fix it. But just extra training, especially for those that have been in the school district a long time. I've come across, I'm sorry, I'm probably monopolizing time, but there are people that have had the training in the education system and mental health side as well. They need to be retrained, they need to get reminders. Everyone is so understaffed and so pressured and so, just tired. In this day and age, it's understandable, but just, try to just remind students and staff alike that just a little extra kindness does go a long way. Thank you.
Thanks, Margaret. Yeah. Hope, and then we're going to move into closing out.
All right, I would just like to say, if money was no object, to really support peer specialists, like really support, give them more living wages, but also, you know, have that more support, and then somehow doing, and I think people have always addressed that already, but recruiting of professionals that could assist in that field is super important. But then I have concerns with too many congregate settings. So if you're, you know, in order to receive services that you might need, you have to live with, you know, 3 other people experiencing similar things. And, you know, at least that's what I've seen.
Yeah, that increased support for peer specialists, and yeah, the different housing situations are always tricky. I feel like, kind of linking it back to what Ellie shared at the beginning, when I was still doing direct service work, I feel like that's where I always ran into the most problems, was people living in those congregate home settings. Barbara, and then I think we'll wrap things up.
Yeah, thank you, Tim, and thank you so much, everyone. You know, I think there have been so many important policy ideas shared here tonight, and that's one reason why I just wanted to remind you that we have a really important election coming up in Wisconsin on August 9th. So all state assembly representatives will be on the ballot, and half of our state senators, the odd numbered senators this year, and also all congressional representatives. And we have a US Senator, Senator Ron Johnson, up for re-election as well, governor and other state offices. So that's really where we have an opportunity to try and make some change to ensure that we elect people who are going to represent the values that we care about and the great ideas that were shared here tonight for increasing access to mental health services and supports. So I'm going to put a few links into the website, into the chat here. We, DRW, in addition to our mental health advocacy, we do a lot of work on voting rights, which are under threat in Wisconsin right now. So we really need your help. We encourage each of you to get involved, make sure you're registered to vote and cast a ballot, but also encourage others in your network to participate. So I'll share the link for My Vote Wisconsin. That's where you can look to share, to check and see if your voter registration is current. Also, many people, because of redistricting, you might have different representatives and senators than you've had previously. So you want to check that out. And you'll want to get informed on the candidates who are running for office in your district, and you can be a resource for them. It's important that they hear from people who are advocates for people experiencing mental health needs and people with other disabilities. So I'm going to put them in the chat right now, and we'd welcome the chance to hear from you to provide assistance one-on-one, or to provide a training or resource materials. It's really an important time for voting rights in Wisconsin right now. So thanks for the time, and thanks to all of you for sharing with us tonight.
Yeah, thanks so much, everyone. We'll keep talking about everything that you shared and, you know, take it from there. But really appreciate everything that you shared. It's really meaningful to me to hear from you guys. And I know the committee and DRW really appreciates it. We'll probably hold it with several more of these throughout the rest of the year and have some other opportunities for you guys to share input. So if you're up for it, we'd love to continue hearing from you guys. Otherwise, it's 7 o'clock on a Wednesday, and I appreciate you guys spending part of your evening with us. I hope you guys get to rest and get some food and do whatever it is you need to do. But I hope you have a good rest of your night.
Thank you. Thank you.
Thank you, everyone. Bye.